All right, everybody. Going to get started. Today we're talking about echo for fluid responsiveness, and Kai wins the award for clever title again. Everyone is encouraged to participate in the next round. This is where we are holding in our curriculum plan in progress. So this is our 5th lecture. The first 4 were really LV 101 and 102, RV 101 and 102. This is the first lecture where we're going to be getting into some bit of integration, which is the whole point. So I'm very excited about that. And the goal for today is to understand the ability and limitations of using echo to predict fluid responsiveness. And as will become clear, it's really impossible to have a lecture about fluid responsiveness that's just about echo, because echo is just a part of predicting fluid responsiveness. But I think that'll become clear, and I'll emphasize the aspect of ultrasound in predicting fluid responsiveness. The subtext here is how to evaluate studies on fluid responsiveness, because many of them come out, and there are some things to look for to determine how helpful they are. So I'm going to start off here with a case. You have a 68-year-old man with HFpEF, comes in with fever, flank pain, hypotension, has a urinalysis consistent with a UTI, a rise in creatinine and lactate, has 3 liters of fluid in the ED, antibiotics, but still is hypotensive. If anyone's not muted, I couldn't, if you don't mind muting yourself, unless you want to ask a question. Received 3 liters of IV fluid in the ED and antibiotics, but remains hypotensive, acidemic, oliguric, transferred to the ICU. Respiratory rate is 26, and he's requiring 100% a non-rebreather, setting 92%. So would anyone here give this patient fluids, or any questions you want to ask, or how would you predict fluid responsiveness on this patient? The floor is open. All right, well, this is a talk on fluid responsiveness, so I guess you can imagine that it's coming. Oh, is there something in the chat? I'd be cautious with additional, yes, thanks, Christian. I don't think I want to, great, okay. So yeah, we shouldn't really be giving this patient fluids, I agree. But maybe if it's a different patient who you would want to give fluids to, you would want to know how to predict, how to assess for fluid responsiveness. So here's our objectives: intro to fluid responsiveness. We're going to go through static measures, dynamic measures, and today is the day that I've been ripping on the IVC a lot, and I've always promised that one day we'll talk about it in more depth. Today is that day, so buckle up, and then we'll review everything. One thing that we're not discussing today is how to use cardiac output, how to get cardiac output via the LVOT-VTI method. That's important for assessing fluid responsiveness, but we've discussed that in a previous lecture. So if you need to review that, I'll make that link available to you. Just let me know. So to go right in, we're going to start off with some introductory remarks about the definition of fluid responsiveness. So what is the definition of fluid responsiveness? Anyone willing to share what factors equal a fluid responsive patient? Don't all shout at once.
Their hemodynamics improve if you give them a fluid challenge.
Yeah, absolutely. And so in the literature, that's exactly the point, that their hemodynamics are improving, and they want, but to be more precise about it, most people, there's no necessarily a scientific definition, but most would specify specifically that it's a 10%, 15% increase in cardiac output in response to 500 mils of fluid. So that's, if you give 500 mils of fluid, the hemodynamic parameter you're looking for is this 10 to 15% increase in cardiac output. And so predicting fluid responsiveness is always going to be about, is there anything we could do besides actually giving fluid to know that if I were to give fluid, they would get this 10 to 15% increase in cardiac output. Now, I would actually change this definition just subtly to stroke volume, because you know that cardiac output is stroke volume times heart rate. And what we're really talking about is not increasing people's cardiac output somehow by increasing their heart rate. What we really want to get at is making sure that we're increasing their stroke volume. So I think a better definition would be 10 to 15% increase in stroke volume in response to 500 mils of fluid. And that's going to be coming up, that's going to be relevant a little bit later. Now, 5 baseline points to begin with before we even start talking about this. The first, as I've already mentioned, is that echo is not the only or the best way to assess for fluid responsiveness. You've probably heard about pulse pressure variation, pulse contour analysis. There are a lot of other tools in the tool shed, and it's important just to know when to reach for which. And second is that fluid responsiveness does not equal fluid tolerance, which is why I think many people were hesitating to give fluid to the patient in this stem here, right? So just because you could be in ARDS and sepsis and you could be fluid responsive, meaning giving 500 cc's of fluid will increase their cardiac output by 10 to 15%, but you also might push a patient into intubation or further worsen someone's hypoxemia. So just because someone would be fluid responsive doesn't mean that it's a good idea to give fluid. The flip side of that also is that fluid responsiveness doesn't mean that there's any benefit. So most people here on the Zoom right now are fluid responsive. If I were to give you 500 cc's of fluid, you'll probably increase your cardiac output. That doesn't mean that you need that. And it doesn't mean that that's going to help you. And we don't titrate fluids to fluid responsiveness. And so ultimately, no predictor is perfect. You have to know the limitations of each, and you have to use your clinical judgment and follow up. And so in my view, when we're going through all the different parameters and different tools that you can use to assess fluid responsiveness, the holy grail or trinity would be if you could find a tool that achieves 3 of the following things. The first is it has to be easy to do. Right? If you have to take someone to the cath lab to get cardiac output, that's not going to be very helpful for you. The second is obviously that it has to be reliable. If it's easy to do, but you can't rely on it, then it's not a helpful tool. And then the last thing that it needs to be is applicable. It needs to be relevant for your patient. If it's easy to do and reliable, but it doesn't work for your patient, then it's also not helpful. And unfortunately, for the most part, the tools that we have available usually can accomplish 2 out of 3, but not all, maybe with an asterisk, which we'll get to. But most tools that I'm going to show you can't do all 3. We don't really have a holy grail yet, maybe. And then finally, I just wanted to take this moment to point out as something that I try to share when I can, that this is another key distinction between comprehensive echo and critical care echo. Comprehensive echo, as I've said, is an imaging tool. If you need to get a really good look at people's valves or strain or things like that, then you need to get a comprehensive echo. The critical care echo is a monitoring tool. So in a situation where you are trying to assess fluid responsiveness and you want to look at a heart before and after, that's not something that you're going to be able to get formal echoes for. And so this is one of the unique applications where critical care echo is doing something that comprehensive echo cannot, because it's just not as available because critical care echo in the right hands is available and useful when you're able to make a serial exam and monitor a response to a change. And then the final thing to point out is the key distinction between static and dynamic measures, which everyone is familiar with. So just to briefly review, there are static ways of assessing fluid responsiveness and dynamic ways. And the static ways of assessing fluid responsiveness don't actually directly assess fluid responsiveness. What they do is they'll assess fluid status or your end diastolic volume. So some static parameter like CVP, based on that, you'll make an assumption of what patient's fluid status is. And then you'll make a further assumption about what their Frank-Starling curve looks like. So for example, you'll have this patient here. So on the x-axis here on the Frank-Starling curve, you have right atrial pressure. This could equally be CVP, LV end diastolic pressure, LV end diastolic volume, anything that really relates to the loading state of the heart. And if you have a low normal CVP, RAP, LVEDP, you might assume that this patient has a normal Frank-Starling curve. And you'll say, well, I use my echo or whatever static measure I have to determine that we have a low CVP. And therefore, I will assume that their Frank-Starling curve is normal. And therefore, by increasing their CVP, increasing the right atrial pressure, giving more fluids, I'm going to achieve an increase in cardiac output. But that's a major assumption, right? You're assuming this Frank-Starling curve and not this one. But what if your patient has this Frank-Starling curve, you give more fluid and you've just done harm, you've done no good, you haven't increased their cardiac output because they're already, even though their CVP is low normal, they're already on the flat portion of their Frank-Starling curve. So a lot of assumptions go into using a static measure of fluid responsiveness. And so this might be helpful at extremes, right? So if you have a CVP of 0, then most people who are not, in severe shock are probably going to respond to fluids. And if you have a CVP of 25, they're probably not. So it might be helpful in these extremes, but otherwise a dynamic measure, which we'll go into depth about, is going to outperform your static measures. So to drill that in, I had to, of course, include a picture of Svi here. So another way of sort of thinking about this is that static measures will guess fluid responsiveness by looking at just a snapshot in time. So it's like looking at this ball here and trying to guess if it's moving towards or away from the hoop, or even if it's moving towards the hoop, if it's on target or if it's going to be missing by a mile. And you can try to look at the wind, and you can look at where its arms are and what he might be doing, and you can make some assessment, but it's going to be limited because you're looking at a snapshot. A dynamic measure is going to look for a response to a change. In this case, the change that we'll insert will be time. And so if you just take one more snapshot after inserting a change of time, you'll notice that, of course, SV scores, because I wouldn't share this otherwise. So that's the power of a dynamic measure of fluid responsiveness, right? So dynamic measures will outweigh static, but will outperform static measures. But everyone seems very used to or cling to, sometimes I feel like, these static measures. And I think dogma eats data for breakfast is maybe a rephrasing of a common phrase, which is that we have to get to dynamic measures, but we still often talk about static measures. And very often we'll be in the ICU, I feel like, and we'll be talking about how we shouldn't be using static measures, but sometimes then we talk about the CVP and then make volume decisions. And so the plea here is to not just talk about how we don't use static measures, but also don't actually use static measures. With that said, I'll briefly share with you some of the static measures that are used for fluid responsiveness. And you can really look at one of two things. You could try to get an assessment of left LV end diastolic volume, or you can get to end diastolic pressure, or CVP, or right atrial pressure. I'm going to go through this very quickly because I already just disparaged static measures, but also because we've covered how to get some of these clips in the past. So if you're looking at LV end diastolic volume, you can use Simpson's biplane method. This is a complicated slide, but ultimately what you're doing is you're basically using your echo in the apical 4 and the apical 2 chamber view to maybe in a way reconstruct what would almost be like a plaster mold of the LV in end diastole, and on that basis, you can assess LV end diastolic volume. It's actually the best way to assess LV end diastolic volume, and it's the gold standard for getting EF. When you get systolic volume and you look at the difference, it's very cumbersome, difficult to do, not necessarily recommended. And again, it's really good for getting EF. It's not really good as a marker for end diastolic, for fluid responsiveness. You can also use LV end diastolic area. This is something that we've discussed in the LV talk. And if you freeze and then diastole and you measure, you can get the area. And maybe if it's less than 10 centimeters squared, maybe that predicts fluid responsiveness. And then finally, you can look for CVP, or you can look at the IVC, which sometimes is thought to relate to CVP. Looking at IVC diameter. We're going to get to IVC variability later, but IVC diameter sometimes is also used as a static measure to assess right atrial pressure, and based on that to make assumptions about the Frank-Starling curve and about fluid responsiveness. And to get the IVC, as you know, you go in the subcostal IVC view, and you have to measure 1 to 2 centimeters from the cavo-atrial junction. You have to avoid the hepatic vein, which is sometimes easier said than done. And you can use 2D or you can use M mode just to sort of get the distance of the diameter of the IVC, and then you can try to make some assumptions. So the reason why we don't do this, and so here's one study that looked at IVC diameter and fluid responsiveness. In blue, you have fluid non-responders. So these are patients who are not fluid responsive. In green, you have patients who were fluid responsive. And this was using VTI and passive leg raise, which is something that we'll get to. That was the gold standard that this was compared to. And they used IVC diameter. And you can see that at an IVC diameter of about 1.2, there is quite a big difference between the curves, but that's only still 80% specific. And at an IVC diameter of greater than 2.5, there's also a smaller, the difference between the curves starts to narrow. So at this point, almost no one is fluid responsive. And this also is a cutoff to be 80% specific for fluid responsiveness. The problem is that, first of all, 80% specific is not great. The other problem is that 70% of patients are in between. And other studies that have looked at the data in more aggregate than just this one study of 500 patients found that the correlation coefficient between CVP and fluid responsiveness in the ICU was 0.28%. So all this is to say that static measures of fluid responsiveness are unreliable, and using the IVC diameter to assess CVP to then make an assessment also similarly unreliable. But I'm going to talk about why the IVC is bad as a dynamic measure as well, which we'll be getting to. So now I'm going to bring us to dynamic measures of fluid responsiveness. And dynamic measures are great because they'll actually simulate a response to fluid without giving fluid. And that's the money, right? So it's not going like a static measure, to reiterate, is looking at is assessing how much volume you have and assuming that if it's low and assuming you have a normal Frank-Starling curve, then you're going to improve with fluid. A dynamic measure is able to simulate what adding volume will do to your cardiac output, which means that to do a dynamic measure of fluid responsiveness, you actually need two things, right? The first thing that you'll need is some method to simulate this change in preload, right? Somehow you're going, without actually giving fluid, you have to figure out a way to simulate a change in the preload. And then the second thing that you need, and this is the key distinction also, the second key distinction between a dynamic and a static measure, is that you need a method to measure that response, to see that when you simulate adding fluid, is there a way to measure that change in cardiac output, or to know, if you're not directly measuring the change in cardiac output, to see something else that indicates that there will be a change in cardiac output. Now, echocardiography comes in here. Echocardiography might be one of the methods you use to measure a response to that simulated change in preload. But there are other methods to measure the response, and echo does nothing in terms of simulating that change in preload. So now you understand why there can't be a talk on just echo for fluid responsiveness, because whatever you're using echo to assess, you still need to discuss about how you're going to be simulating that change in preload. And then even if you're using echo to monitor that response to a change, you have to figure out, is echo the best way to do it? And if so, how? So I'm going to first list, this is the slide that's going to be sort of the baseline for the dynamic measures. And I'm going to keep referring back to this slide in different ways. So first, like I said, you'll have to simulate a change in preload. And there's two ways basically of doing that broadly. The first way is to change intrathoracic pressure, right? With high intrathoracic pressure, you get less preload, and then you get lower. If you lower intrathoracic pressure, you get more preload. So breath to breath, you're able to simulate a change in preload. The other way to do it is just change the amount of volume or distribution of volume that's already within the patient. So to go into this in a little bit more detail, right? So very often you probably are familiar with using tidal volume on a vent, right? Which will change intrathoracic pressure, change preload, and might be the way that we could simulate a change in preload. There are some studies that don't even necessarily care so much about the tidal volume, but just look at doing an end expiratory occlusion. So an end expiratory pause, like you're checking for auto PEEP, and just using that to simulate the change in preload compared to what happened previously. I'll show you. And then you have spontaneous breathing, where you have patients who are not on a ventilator, but just as they breathe in, they decrease intrathoracic pressure, and as they exhale, it increases. And these changes in intrathoracic pressure can correlate with a change in preload. The other thing you could do is change the volume of distribution. The best known way of doing that is a passive leg raise. So you have some fluid that's in the higher capacitance vessels of the lower extremities. You do a passive leg raise. We'll go into this in a little bit more detail also, but you're able to push some of that peripheral fluid centrally and therefore increase your preload for a specific beat or two. That's the main way, because the other ways are really cheating. There's mini fluid challenges. So you're not really simulating, you're actually giving fluid, but a small amount, which has been studied. And then there are studies that will actually do a fluid challenge, which to me defeats the whole purpose of the whole concept of predicting fluid responsiveness. If you're giving an actual 500 cc's, but you still will see studies about using fluid challenges. So these are the main methods. This cannot be comprehensive. There are others, but this is a fair overview of what's out there. And so you have your way that you're changing your preload. And now what you have to do is you have to measure the response to that change in preload. And you can do that either directly or indirectly. And by direct or indirect, I mean directly getting a cardiac output, or not directly getting a cardiac output, but seeing a change that correlates with a change in cardiac output, which I'll go through. So direct ways to measure cardiac output would be a PA line, but it's pretty timely to wait for your fix or to get a thermodilution. Pulse contour analysis, which is real-time continuous monitoring using some proprietary algorithms based on an A line that's used very frequently in the OR. We have a couple of them on Blake 8, not I think as available on Blake 7, also not frequently used so much on Blake 8, but it's one fancy new technology that's emerging. Then you can use echo using the VTI method to directly measure cardiac output, which we've talked about in the past. And then there are also bioreactants or impedance like the NICOM, which some of us have used. These are all methods to spit out an actual cardiac output. So you can potentially use these to measure before and after any of these simulated changes in preload and see if they change your cardiac output. The indirect methods would be something like pulse pressure variation, where you see I'm not going to get into this in depth either. It's a talk for another time that many of us are familiar with. But pulse pressure variation does not actually tell you a change in cardiac output, but we've done enough studies to know that if there's enough pulse pressure variation, that correlates with a 10 to 15% increase in cardiac output. Or you can use echo to look at IVC variability or even SVC variability, which is something that we'll get to as well. And so one key takeaway here is that when you're reviewing a study on fluid responsiveness, you have to be able to identify both components. If you talk to many people and ask them what is the best method for dynamic measures of fluid responsiveness, many people will tell you pulse pressure variation, right? Which is a fair claim. But pulse pressure variation, as you can see, is half the story. Pulse pressure variation and what? Right? And so the answer is usually tidal volume on event, which has a lot of limitations. So we'll get to that. But whenever sometimes the studies that you might read on fluid responsiveness aren't actually directly clear or explicit about what they're using to simulate their change in preload. It's obvious, it's always there, but sometimes it's not laid out for you as this two-step process, which it always is. And then, of course, as you can see, so in theory, you could take any change on the left, any method of simulating a change in preload on the left, and connect it with any method of measuring response on the right. And many of these studies have been done. Maybe every single one has been done. And I'm not going to be able to go through them all either. So today I'll be picking out some of the key ones, things that have been repeated, things that have been accepted. But the main challenge is that even if you could, in theory, do these all, you have to know the limitations of each method because they all have some. And so that's what we're going to sort of be focusing on for the crux of the dynamic portion of this talk. So a change in intrathoracic pressure, if you're using tidal volume on the vent as your method of changing intrathoracic pressure, as your method of simulating a change in preload, then you have to be aware of many of these problems. Number one, generally you have to be on a high tidal volume. It's 8 cc's per kg. This is Seek loves to ask this question on the critical care board review. But the tidal volume has to be large enough in general to simulate that change in preload. You have to have normal lung compliance. You have to be passive on the vent, because if the patient is at the same time putting in spontaneous efforts, so then you're going to have some negative pressure combining with positive pressure, and you'll never know. It's basically not standardized to whatever to whatever amount of pressure is usually generated by a change in tidal volume. If you don't have normal lung compliance, then you might not be transmitting the pressure to the intrathoracic space. Sinus rhythm. In the interest of time, instead of asking, I'll just explain that you need to be in sinus rhythm, because if you're not in sinus rhythm, then with every beat, you'll have different filling. And you can't time, so one beat will have more filling time and therefore will have a higher stroke volume. The next beat will have a less filling time, will have a less of a stroke volume. And if you're at the same time that you're doing that, you're also on a respiratory rate and you're trying to assess the changes in response to different to a tidal volume or no tidal volume, you'll never be able to synchronize that. Basically, you have two things that are moving dissynchronously at the same time. And maybe more relevant for Blake gate, you have to have a closed chest, or else again, the pressures aren't transmitting. So these are a lot of complications of using, a lot of limitations in using the vent as your method and the tidal volume as your method of simulating a change in preload. That said, the vent has been used very frequently in a lot of these studies. I'm not going to get into the poor studies using echo, poor studies using echo for both VTI and IVC, good studies for pulse pressure variation and SVC variability. So I'm going to dive into those for a minute. But remember that, so when we're talking about pulse pressure variation, it's going to be limited by all those limitations that we just mentioned. So I'm not going to go in depth into pulse pressure variation, but this is what you're seeing, right? You have a change in this is the respiratory cycle and expiratory pause. You have a pulse pressure, you have a change in your pulse pressure. And if your pulse pressure changes by 12% with all the caveats that we just mentioned on a vent, so these studies are connecting pulse pressure variation to the respiratory cycle on a vent, then you have pretty good sensitivity and specificity. Area under the curve is 0.94 for a cutoff of 12%, meaning that if you are getting a 12% difference in pulse pressure variation for a patient who is on a vent, that would suggest that if you were to give them 500 cc's of fluid, their cardiac output would improve by 10 to 15%. But there are some caveats, as you might notice here. So number one, these patients' pulse pressure variation, at least in this study, and this systemic review and meta-analysis has been validated in mechanically ventilated patients who have to have a large tidal volume with spontaneous breathing and no cardiac arrhythmia, no AFib, right? So if you have all these things, then pulse pressure variation is great, and you might not need your echo, and you shouldn't use your echo. But if you don't, then all the rage and all the good rep that pulse pressure variation has sort of goes out the window. So I would say that pulse pressure variation is arguably not so applicable because there are a lot of caveats it's quite reliable, and I'm not sure how simple it is. If someone knows a really easy way of accurately measuring a 12% difference in pulse pressure variation, maybe I'll turn to some of our anesthesiologists. That would be a great trick to learn, but at the bedside, it's not necessarily the simplest thing to, at least for me, to figure out. But maybe that's just something I need to learn, and maybe it's easier than I think. So I gave it a question mark. Now, what about SVC? So first of all, during the respiratory cycle on a mechanically ventilated patient, does the SVC collapse on inspiration or expiration? Anyone care to share? Got chats, you can set up monitors to automate. Oh, thanks, Christian. We should talk about that after. So one thing just to keep in mind when we're talking about variability for the SVC and the IVC is to remember, are you looking for collapsibility or distensibility? And the equations that are used also sort of matter. So to that point, as SVC is intrathoracic, right? It's in the thorax. So when you have a patient who's mechanically ventilated on positive pressure ventilation, with inspiration, the SVC will be forcibly collapsed by that increased pressure. And if you take the maximum diameter minus the minimum diameter over the max, and it's greater than 36%, it's 90% sensitive and 100% specific for predicting fluid responsiveness. It's actually really accurate. The only problem, of course, is that you need a TEE, right? And that's not so available. And so this is not simple. It's not applicable because you still need to be all the patients who are on the vent, and you still need to have all those caveats that we mentioned earlier, but it is reliable. And I'm going to get more into IVC variability in a little bit. So back to here. So we talked about tidal volume on the vent, connecting it with pulse pressure variation, connecting it with SVC variability. There's also end expiratory occlusion, which has been studied, where people aren't so caught up in the tidal volume, but have done studies connecting end expiratory occlusion with pulse contour analysis, and which I'll show you on the next slide. And that has demonstrated also to be a reliable measure of fluid responsiveness. And so you'll notice that what end expiratory occlusion is doing is that at end expiration, you're sort of just holding that increased intrathoracic pressure. So it's actually a little bit of a more subtle change than the tidal volume on a vent, because when you're using tidal volume on a vent, what you're sort of measuring is or what you're simulating with pulse pressure is the change from one extreme to the other. You're getting the effect of peak end expiratory pressure to minimum end inspiratory pressure, excuse me, vice versa. But for end expiratory occlusion, you're just looking at that end expiratory pause compared to what the cardiac output sort of has been until then. So you need actually a finer tool, which is one point about one benefit of pulse contour analysis. It's a finer tool to measure changes in cardiac output. And so that's the only one I'm going to go through. There was one study on using pulse pressure variation, but there have been good studies on using pulse contour analysis. And I think the reason why it's mostly being connected with pulse contour analysis is because of this point, because you need to have a little bit of a finer measure. So if you're using an expiratory occlusion, you have to have this real-time cardiac output monitoring. This is what pulse contour analysis will show you. And you're at a baseline, and you have a cardiac output measured over a period of stability, right? And you have sort of an overall cardiac output. Now for this, you might notice that arrhythmia might not matter, because you're getting sort of a baseline over time, and you're not worried so much about the beat to beat because you're not looking at respiratory variation here, right? And then you have an end expiratory occlusion, which is just like the end expiratory pause you do for measuring intrinsic PEEP, and you do it for 15 seconds, and you might notice your cardiac output changing. And then you see if they returns to a baseline, and then if it changes by 5%, so I'm going to bring that all the way down here. If it changes by 5%, then this patient will be likely to be fluid responsive. So at end expiratory occlusion, not so when you're holding sort of the lowest pressure in the chest, you're seeing that the cardiac output is rising, and then it returns to baseline when you stop the occlusion. That if there's a 5% difference in cardiac output right here on your pulse contour analysis, then you can be somewhat confident that this patient is fluid responsive. It might not be as reliable in patients who already have a high PEEP or are prone, perhaps not in low tidal volume. These are things that have to be actively explored. Now, can you use echo for this? Why not just use the LVOT VTI if you don't have pulse contour analysis? Can you use echo to measure the same thing? Just look for that 5% change in cardiac output, and if you with your end expiratory occlusion, and if you have it, you'll be confident that this patient's fluid responsive. Any thoughts? It's like a trick question. Your heart says no, but I'm the echo person, so I want you to say yes. But the answer is no, you can't use echo. And so this is one important point too. And the reason is because the inter and intra-user variability of VTI of cardiac output on echo is actually 10 to 15% respectively. So if you do a VTI on the same patient a few times in a row, you can expect to be have an 11% difference from each try, even if there's been no real change in their underlying cardiac output. If you do it with a different operator, so you and someone else who's equally well trained, there could be a 15% difference. So you can detect larger differences with echo, but you can't actually detect a 5% difference. And so the end expiratory occlusion wouldn't work. There have been studies that connected an end expiratory occlusion with an end inspiratory occlusion and then make the argument that maybe you could use LVOT VTI, but I'm not going to get into that today either. So end expiratory occlusion with pulse contour analysis is simple, is reliable, is not so applicable if you don't have it. But if you have pulse contour analysis, this might be a holy grail, but we'll get back to that discussion. But also depends on how much you trust it, which in general, I think people tend to. So what about spontaneous breathing patients? Spontaneously breathing patients, so there have been really, really poor studies on using IVC variability to predict fluid responsiveness in a spontaneously breathing patient. And so now is, I think, the time where we're going to dive into this a little bit more. So it's very simple to do. It's applicable for anyone who's spontaneously breathing. The problem is it's just completely unreliable. And so now I'm going to launch into the into why I dislike the IVC so much for fluid responsiveness. And part of it, I think, is also because it's so easy to do that it's so tempting to rely on it. But hopefully in the next few minutes, I'll convince you not to do that. The first issue is something that I already alluded to, which is just confusion regarding variability and what it means. This is not insurmountable, but there's very poor data overall. There's many different studies with many different cutoffs. Now you have to remember that when a patient is being mechanically ventilated, then on inspiration, the IVC distends because the IVC is extrathoracic. So when you're increasing intrathoracic pressure with inspiration on positive pressure mechanical ventilation, it sort of obstructs return. It obstructs venous return from the IVC. So the IVC distends. So you actually don't use the term IVC collapsibility for a patient who's mechanically ventilated. It either distends and then goes back to normal. So it's distensibility. And that range that's been studied for the studies that have tried to use IVC distensibility to associate that with a change in cardiac output require a narrow 12 to 18% range. Those are sort of in the different studies, those are sort of the cutoffs that are supposed to help you figure out whether or not a patient is or is not fluid responsive. And part of the confusion also, so that's first of all a pretty narrow range, and there's a lot that can make you be off by that. There's a lot that can lead you astray there. The other thing is that different studies study different things, and the equations by some will look at IVC max over IVC min. Some will look at IVC max over IVC mean. Some will look at the difference over the max. And so that leads to a lot of confusion about what each study is doing. It's already a pretty narrow range, and then on top of that, different studies have different results regarding whether or not it's accurate. So overall, it's pretty inaccurate. When spontaneously breathing, then we're looking at IVC collapsibility. With inhalation, you decrease intrathoracic pressure. I sort of feel like that IVC fluid is sucked into the thorax, and so the IVC does collapse. And so there, generally, the studies that use IVC collapsibility for a spontaneously breathing patient usually are looking for collapsibility in the range of 40 to 50%. But again, you have conflicting data regarding how accurate it is. So the first issue is that it's really confusing, lots of different data, lots of conflicting data, and narrow range for mechanically ventilated patients. So you have papers like this one from Scott Millington. Using the IVC for fluid responsiveness is easy and fun, but unlikely to be helpful. And then you have papers that talk about 10 situations where IVC may fail to accurately predict fluid responsiveness. And I'm going to walk you through some of these. So first, we're going to go through some of the technical problems. And the first technical problem is choosing the right site. I mentioned earlier that you have to place your marker about 1 to 2 centimeters from the cavo-atrial junction, but you also have to avoid the hepatic vein. And you might notice if you've put your probe on enough patients that number one, the hepatic vein can really get in the way. And number two, the IVC shape can change a lot in the 1 to 2 centimeters. So here you have a patient where here's your cavoatrial junction. You can't put your marker here because you've got the hepatic vein. So you got to go here or here if that's still within 1 to 2 centimeters. And you can see that these are actually quite different diameters. Look at this IVC where the diameter also changes quite quickly and rapidly. Here you have an IVC where it's narrowing even sooner. You could get your IVC here or your IVC here, both technically within probably 1 to 2 centimeters of the cavoatrial junction. Totally different report readings. Here you have another cavoatrial junction where you can't really measure anything until out here, which is more than 1 to 2 centimeters. And so here you also have this IVC where it narrows quite quickly as well. So this, you put the line here, but you put the line just there, you're getting a very different read. So where you place your marker really matters. And it's really hard to really truly standardize this. So all these studies that are relying on this already have this major limitation. Let's move on to the cylinder effect, which or before I do that actually. So number 2 is you have to be on the right axis. So if you're using M mode, or even if you're just using even if you're just on 2D and frozen and measuring a distance, if you're using your M mode, if you're not perfectly perpendicular, you're going to falsely elongate or widen your IVC. I'll show you that here. So here you have an IVC that's 2 centimeters. And if you put your M mode perfectly perpendicular, you're going to get 2 centimeters. But if you're off angle, you'll end up reading 3 centimeters. And this will look exactly the same as the image on the left, but it'll be longer. This one is subtly off angle, right? Not probably making a big difference, but you could be off by more. And the other thing just to remember that I don't have a slide on is that often when we're looking at the IVC, we're at pretty great depth. Sometimes we're at 20 centimeters if you're doing this from the subcostal view. So things that look like no difference at all can actually be quite a big difference because at 20 centimeters depth, subtle changes are actually more than you might be able to appreciate. I've mentioned the cylinder effect before, and here we're finally talking about it. So you have to bisect the IVC if you want to accurately measure. So if you want to measure your 2 centimeter IVC, you've got to measure it right here, but you might not realize that you're actually here. And that's your cylinder effect. And so you're reading an IVC of 0.5 centimeters, when in truth, the IVC is 2 centimeters, and you just don't realize that you're sort of getting its edge. The other problem is that the IVC actually moves during the respiratory cycle. So where are we? So the IVC can move both mediolaterally and craniocaudally. So you have mediolateral movement in respiration, which can create false collapse. So you have this patient take a deep breath, breathe in, or inspiratory or positive pressure breath, and this happens. I lost some of my animation here, but just moves over, right? And so now it's 2 centimeters, but it really didn't change at all. But your M mode on the side can look like you got this perfect collapse. But really what happened is that your IVC just moved to the side and didn't collapse at all. And that can happen in the longitudinal way as well. When the heart contracts, it sort of pulls the IVC with it sometimes. And so you can have the IVC moving. I lost another nice smooth transition animation. But if you see that your heart might be, your IVC might be just, you might be holding your M mode right here. And with the cardiac cycle, the IVC just sort of moves to the right, and you're going to be reading this collapsibility, even though the IVC hasn't changed at all. Major problems. Here's another problem with the IVC. What's the problem with this IVC? Problem with this IVC is that it's an aorta, but it's extremely easy to confuse them. Look, here you have IVC, aorta. Flip IVC, IVC, aorta. Right? They're very close, very easy to confuse, and then you'll get very little collapsibility because it's an aorta. You might measure that pulse and think that it's collapsibility. These are things that you can get over, but these are one of the issues why when people are starting out using IVC ultrasound to measure collapsibility and measure fluid responsiveness, there are so many things that can go wrong. These are all just technical problems of the image acquisition. Yeah, thank you, Michael. Correct, not the IVC, that's a major problem. And then there's IVC confounding problems, which are a lot of the ones that sort of are the same for anyone who's mechanically ventilated. If you're on a high PEEP or a low tidal volume, the impact of lung compliance, if there's a lot of spontaneous effort, you won't know how much that's contributing to your collapse. If there's RV failure, then you might have a large IVC that doesn't really correlate with fluid responsiveness. If you have high intra-abdominal pressure, that can also affect your IVC. And people who are hyperinflated from asthma and COPD, there are a lot of IVC confounding problems with interpretation. So you have a whole litany of problems in image acquisition, this whole list of IVC confounding problems, which is probably the reason why you have so much conflicting data in these studies that already try to get you to capture a very, very narrow window. So the problem with the IVC is that it's simple, maybe it's applicable, but the problem is that it's missing the most important one, which is that it's reliable. And if it's not reliable, it's not usable. And so that is the long-awaited hatred of the IVC. So if you don't agree with that, then you can go ahead and use it. Going back to dynamic measures. So I briefly mentioned that there have been studies using a mini fluid challenge. And then that study, similar to using end expiratory occlusion, has been correlated with pulse contour analysis. And I think for the same reason, because if you're giving a small amount of fluid, right, so you're saying, okay, instead of giving 500 cc's, I'm only going to give 100, you're sort of compromising. Then you need to be able to capture a very subtle change in cardiac output to know that there's an improvement. And so pulse contour analysis is one of your best tools for that. I'm not really going to talk about an actual fluid challenge because that defeats the whole purpose of this entire talk. So now I'm going to focus a little bit more on the passive leg raise. And the passive leg raise is actually really substantial, actually easier to do than you think. And it's been connected with pulse contour analysis, echo VTI, impedance, bioreactance, and impedance with really great reliability. And so it's important to really first know what exactly is happening. So what you're doing is, by doing this passive leg raise, you're sort of auto-transfusing approximately 300 cc's of fluid from the lower extremities, a little bit more, which I'm about to get to, into the more, the cardiac circulation. So for a minute or so after you do a passive leg raise, they are simulating you've actually increased effectively intravascular volume that the heart is seeing on its preload, on its Frank-Starling curve. And this works in patients who are spontaneously breathing. This works on patients who are low tidal volumes, low lung compliance, because this doesn't rely on intrathoracic pressures. It really doesn't matter at that point. And it even works for arrhythmias because you don't need a change beat to beat. You don't need to look at a change breath to breath. You can look at an overall cardiac output and then do a passive leg raise and then look at an overall cardiac output, and the averages can still change, which is different than if you're using any of the mechanical ventilation parameters. The thing is that you have to do your passive leg raising correctly, and there are some things that I think are just not very well known. So they're all listed over here. So the first is that you have to start with the trunk at 45 degrees on the bed. You don't want to start with the patient lying flat. And the reason for that is that there's also a thought that not only are you redistributing some of this lower extremity venous volume, but that there's also some blood in the splanchnic circulation. And so if you start off a little bit upright and then you do a passive leg raise, you're going to be recruiting that fluid as well. And it makes the passive leg raise more sensitive. There have been studies, I believe, that have shown that. I don't think it's just in theory. So you want your patient on the bed sitting at 45 degrees, almost like many of our patients already are. And then step two is you want to use the bed adjustment and avoid touching the patient. You don't want to, and you might see or have seen people sort of take the patient, grab them by the legs, lift their legs up and do their passive leg raise. And the problem with doing that is because, as I mentioned at the very beginning of the talk, that can cause pain, discomfort, agitation. You can affect, and those can have an impact on cardiac output. Those can also affect the heart rate, which can impact cardiac output, right? And once you're doing, then what might end up happening is you'll have an increase in cardiac output, but it's not actually solely due to the increase of that auto transfusion. So you might falsely get a false positive basically by increasing the cardiac output through a different way. And then you'll be surprised when you give fluid after and find that you actually did not increase their cardiac output. So you want to do a really soft and subtle, gentle lifting just using the bed buttons. And number three is, and this is sort of something that I already mentioned, you want to use a direct measurement of cardiac output because arterial compliance will confound the findings. So if you try to use pulse pressure variation, it won't be as accurate. This is probably true of all the indirect methods of cardiac output, and just the proponents who have been studying and pushing for passive leg raise have been strategic, I believe, in just using direct measures of cardiac output as their outcome, to make sure that the passive leg raise as a tool still remains useful. You could still study passive leg raise with pulse pressure variation, and it has been done, and find how useful or how reliable or how accurate that is. But for most studies that are pushing, most people who are advocating for using passive leg raise, they'll tell you only use this with the direct measures that I pointed out earlier. The other thing, and I can't fully explain this, I'm sure smarter people than me on the call can, the passive leg raise effect vanishes after a minute. And so that's why you actually still, maybe it redistributes again, I'm not sure. It's just what actually happens in clinical practice. And so you need to have this real-time monitoring of cardiac output. You can't use your thermodilution on your PA line and get it before and after, because that effect is going to vanish before you can get those answers. And that's why you'll need the continuous output monitoring of pulse contour analysis, LVOT VTI, or bioreactance and impedance. And then you have to go back to the baseline and see that that goes back to normal, that the cardiac output returns to normal. And that will sort of be a check on the issues that I raised in number 2 here. It sort of ensures that this change was spontaneous, that it was due to your passive leg raise and not due to something else, that may have happened at the same time, or maybe not triggered by pain or agitation or something like that. And so if you do this passive leg raise correctly, and just this slide is just a shout out to remind everyone that the LVOT VTI is, for those who don't have pulse contour analysis available, is a really good method of doing this. And in fact, you can keep your echo probe on the chest at the same place and have somebody else, or while somebody else is maybe doing the passive leg raise. So because it's all quick, the whole thing is about a minute or two. And so you can actually start to get your changes in your VTI. And as we discussed when we talked about VTI, that you could again remember that VTI correlates with stroke volume. To get cardiac output, you need to input heart rate. But here, as I mentioned at the beginning of the talk as well, what we're really looking for is a 10 to 15% increase in stroke volume. So you don't need to get your LVOT diameter. You don't need to get an actual cardiac output measurement. You can just get your LVOT VTI and measure one from before and one within the minute after, and see if it's changed by 15%. And in this meta-analysis that has studied all of these different methods, so they've connected passive leg raise with all of these methods, transthoracic echo, pulse contour analysis, bioreactance. So it might not be the simplest, right? Passive leg raise is not the simplest. It's simpler than it might seem, but it's reliable and it's applicable. You could do it on almost all patients, vented or not vented, arrhythmia or no arrhythmia, tidal volume, no tidal volume, right? So very applicable, very reliable, not the simplest, but not so difficult to do and shouldn't take more than a few minutes. If you have pulse contour analysis, it's a nice thing to maybe get used to playing with. I haven't become so comfortable and familiar with using it yet, so I don't know if maybe there are any caveats I should be aware of. But to do it with LVOT VTI can also work really well, and you can see that the area under the curve is all around 90%. And so if you don't have pulse contour analysis, I give this the holy grail. If you don't, pulse contour analysis connected with maybe end expiratory occlusion, I think this would have, regardless, I think this is sort of the holy grail, either for having 2 out of the 3 for not being simple, but still being reliable and applicable. If you have pulse contour analysis, it might be even simpler. So this is probably your best method of fluid responsiveness, which doesn't necessarily require an echo. As much as it pains me to say. What I haven't discussed in this talk, which is not for today, is diastology and vexus. These are different methods. These are also sort of semi-advanced echo techniques that are really used to assess not so much fluid responsiveness, but they're good ways of telling if you're fluid overloaded or congested. And so if somebody uses diastology to see that you're fluid overloaded or vexus, that would probably be a sign not to administer fluids. It's sort of getting at fluid responsiveness from the other direction, sort of proving that you've already overshot. So something to be aware of that they exist, but we're not discussing those today. So in sum, the overall approach to wrap this all up, the overall approach to fluid responsiveness by echo is you first have to ask the question of, is there impaired tissue perfusion, right? Getting at, if you're not fluid, just because you're fluid responsive does not mean that you need to be given fluid. So if there's impaired tissue perfusion and you think that giving them fluid or increasing their cardiac output, I should say, is their best method of improving their impaired tissue perfusion, which probably is, then you move on. And then the next question is, are they fluid tolerant? Because there are other ways to improve patients' cardiac outputs without increasing their fluid. So you want to make sure that you're not hurting them. Are they in ARDS? Are they about to get intubated? Are they already intubated and peri-VV ECMO? Then you probably don't want to give them fluid, so it also doesn't matter. But if the answer is yes and yes, then you want to, and you're thinking that maybe giving fluid will be the best way to increase their cardiac output, increase their perfusion, you have to ask yourself, how will I simulate the fluid bolus? What are my options? So if they're intubated, then you have more options. You could use tidal volume as long as they are passive, normal lung compliance, low respiratory rate, 8 cc's per kg. There have been studies that have transiently increased patients to 8 cc's per kg to do it, and it seems to be safe and fine. They have to be in sinus rhythm, and expiratory occlusion, same issue. If they're not intubated, or they're intubated but have any of these many caveats, you can use your passive leg raise. Or if you're willing to give a little bit of fluid, you can consider doing a mini fluid challenge. And once you decide how you're going to simulate that fluid bolus, then you have to determine how you're going to measure a response. And you have to use a measurement that's capable of measuring whatever it is that you used to simulate the fluid bolus. So pulse pressure variation, if you meet the vent criteria, that's a fair way. SVC, but you'll need a TEE, some SVC variability, but you'll need it for patients who are vented also, but you'll need a TEE. They also still have all the issues for patients who are mechanical ventilation. And one issue that I didn't mention for passive leg raise is that for patients who have increased intra-abdominal pressure, and obviously patients who have lower extremity amputations, so you won't be able to use passive leg raise. So you might want to use an SVC for some of those patients. Any of these other ones for the other patients, but for patients who have increased intra-abdominal pressure, SVC might be better than using IVC or passive leg raise, because that's sort of already the increased intra-abdominal pressure is going to impact your IVC and your passive leg raise. You can use VTI, but it's great and not easy. Pulse contour analysis, really great, not often available, and maybe it will be the holy grail. So in this patient at the very beginning, there was impaired tissue perfusion. Is the patient fluid tolerant? No. So we should stop, as everyone sort of said. But if the answer was yes, then how would you simulate the fluid bolus? This patient had no vent. You wanted to avoid fluid, so you would try a passive leg raise, and then you would use a VTI or pulse contour analysis if it's available. And to finalize some of the summary points here, fluid is not the only way to improve cardiac output, even if they're fluid responsive. So keep tabs on emerging data on fluid in various shock states. I think we're in like an era where more and more studies are just coming out saying fluid is bad and early pressors are better, maybe. So this might all be moot if like we completely move away from, you know, even the amount of fluid resuscitation we already do. So this is all dependent on the data about fluids in shock. There's no fluid responsiveness prediction method that's perfect or that should be used alone. Ultimately, you have to make your best decision. And when you're assessing studies on fluid responsiveness, make sure that you know the study population and make sure you know what combination of fluid stimulation and cardiac output read has been employed. And happy to take any questions. All right. If no questions, I guess I will end us here. Thank you all for coming, and happy to chat offline at any time. Take care.
Thank you so much, Jonah.
You're welcome. Thanks. Yes, I will make a recording available.